Welcome, everyone. I'm excited to welcome you to this episode of Sunflower, a podcast exploring all aspects of children's palliative care around the world. We're going to bring curiosity, humor, and reflection to the world of palliative care, exploring the joys and challenges of working in this incredible field. I'm one of your hosts, Megan Doherty, and I'm here today joined by Dr. Erin Kwolek, a specialist in pediatric respirology and palliative care from Ottawa, Canada. Welcome, Erin. It's great to have you on the show.
Thanks for having me.
And do you want to just introduce yourself a little bit for our listeners?
Sure. My name is Erin Kwolek, and I'm a pediatric palliative care physician at the Children's Hospital of Eastern Ontario in Roger Neilson House. I also have done work as a pediatric respirologist. I'm a Royal College certified pediatric respirologist who finds myself working in palliative care full-time.
And that's so great. And, that's one of the reasons we wanted to have you on the show, was just to hear about this really unique set of experiences and skills that you bring to palliative care as a pediatric respirologist. So tell me a little bit more about that journey of coming, and training, and how did you get to where you are now?
I had an interest in palliative care that sort of came about during my medical school training. I did some electives in adult palliative care. And then when I started my pediatrics training, I did some early training on respirology, and there weren't a lot of formal training programs in palliative care. And one of the respirologists I worked with let me know that there was a lot of co-management of pediatric patients between respirology and palliative care, and so I pursued that training.
Great. And I love this point you bring up about how there's this co-management of respirology and palliative care patients. Can you tell us a little bit about that? Because I think that's kind of new for our listeners. And you had talked about how in adults this is pretty common.
Yeah, so doing both palliative care and respirology is quite common in adult medicine because of things like lung cancer, which is not something we see a lot in children, and because adults have bigger airways. So there's actually a whole field of what we call interventional respirology, where respirologists use bronchoscopy to do things to manage their patients. So, for example, putting stents in airways that are being compressed by tumors, placing drains for pleural effusions, whether they're malignant or even things like pneumothoraces. So really, because of that, this is quite a bit more common in adult medicine. In pediatrics, what we see more is children with medical complexity who have underlying respiratory issues, whether they're upper airway obstructions, whether they're hypoventilation related to low muscle tone.
Lots of different issues, but some overlap is interesting. Yeah. And, I think one thing you're really interested in when we were chatting was just this idea of how pediatric respirology and respirology in general can be a big enhancement in quality of life. And, in palliative care, we love talking about quality of life. So tell us a little bit about what's happening in the literature there.
Yeah, I think there's sort of two big things that we're seeing. And certainly the area of sleep medicine is really developing a lot within pediatric respirology. And a lot of children who are followed by palliative care teams who have neuromedical complexity have sleep issues. So obstructive sleep apnea, sleep hypoventilation. When you have poor quality of sleep, we know that you have poor quality of life. It's hard to have the energy for the day to do the things you want to do. That's such an important part of palliative care. And even for children who can't communicate why they're not feeling well. So we're seeing different applications of respiratory technology, whether it's things like non-invasive ventilation, CPAP, but even things like heated high flow being used to sort of improve sleep apnea. There's some new research coming out on that.
Yeah, and maybe just tell our listeners, because I don't know if everyone's super familiar with heated high flow, because it's kind of a new thing and not available in every setting. Can you just describe what it is?
Yeah, so heated high flow oxygen allows us to kind of use nasal prongs to deliver a higher amount of flow that's humidified. And so what we're able to do is we're able to deliver more flow without damaging the airway, without causing nosebleeds, with a lot of dryness that you would get with traditional nasal prongs. So we can deliver a higher amount of flow, we can deliver oxygen, we can actually distend the airway a bit and deliver end expiratory pressure, a small amount of end expiratory pressure.
Okay, so this is kind of a new thing that's coming, and I'm sure we'll see it more and more in palliative care.
Yeah, it's very well tolerated and very, very low risk of adverse events associated with it. So I think we're going to see more companies developing technology for our patients to use in our communities.
And is that something that's available right now for patients in your community, like where you're practicing?
Yeah, I would say there's limited availability. And it's just because the sort of platforms that deliver this at home are very expensive. So really getting coverage is very difficult to sort of deliver this care at home. But I think the research is really supporting an increased application of the technology.
So it could be something that we see more in hospitals too, even if it's not going out into the homes in the
Yeah,
beginning, I guess.
yeah, I think that definitely reflects what we've been seeing the last kind of 5 to 10 years in ICUs and in wards and hospitals.
And you were mentioning a little bit about how it supports quality of life and is heated high flow. Can you tell us more about some interesting studies that have just come out?
Yeah, so there was a publication in the Journal of Sleep Medicine that came out this year. That's actually based on a population of children with medical complexity. I think 2019 to 2021, done out of the Hospital for Sick Children in Toronto, showing that heated high flow and CPAP, when titrated in a sleep lab in a group of patients who had obstructive sleep apnea, actually there was no statistically difference in the changes that they were able to make in terms of these objective measures of sleep apnea.
So just as good as
Just
CPAP.
as good as CPAP, yeah.
Oh, that's really interesting. So that might be where things are going in the future.
Yeah, I think significantly better tolerance for this technology as well. It's quite a bit more comfortable.
So it's kind of a better option than CPAP for
Yeah.
some kids. And then I know you've talked a little bit about assisted ventilation, but there's another type of assisted ventilation that's really helpful. I heard you talk about sip and puff.
Yeah, and sip and puff is a respiratory technology that is used a lot in adult populations. And what it is it's like a straw that a patient can kind of initiate a breath with. So their breath is supported with a bit of pressure from that straw, and it helps with recruiting lung volume and helping get a good strong breath in. And the nice thing about it is it really supports the patient choice and the patient autonomy because that straw sits in front of them and they can choose when they need it. So they can still do the things they want to do, talk, eat, without having a ventilator or anything kind of sitting on their face at all times. But they get to choose when they have the intervention, when they need it most.
And from what age can kids be sort of able to use this kind of technology?
I think I've seen it mostly in teenagers, but I think that's just because of who's been using it traditionally. So when we think of adults using a particular technology, usually we sort of transition to teenagers using it first because physiologically a teenager is very similar to an adult. But I anticipate that we'll see it used more and more in younger children who maybe don't want a non-invasive or tracheostomy with a ventilator, but who still kind of need that lung volume support.
And what kinds of diagnoses have you seen it used for? Just so our listeners can kind of picture the types of patients who might need such a.
I think probably the biggest group I've seen it used for is patients who have neuromuscular disease, so patients who have a lot of weakness. When we breathe, our brain tells us what rate we're going to breathe at, and our lungs that are healthy enough to breathe do the work that they're going to do. But we have muscles that support our lungs that we kind of use unconsciously. And when those muscles are weak, it's hard to get those big, deep breaths that we need.
Yeah, and we see a lot of those neuromuscular patients. They would be followed by palliative care or provided with palliative care, I guess. Duchenne muscular dystrophy patients is a big group that comes to mind for me.
Yeah, and that's where a lot of the research with this kind of technology has been done, that particular patient population, because these are patients who can have an understanding of what the technology can provide and who've also previously had a bit more muscle strength. And as their illnesses progress, they sort of have an appreciation for the need for that kind of support.
Okay. And you talked to me about the things you love about respirology, and I thought that was kind of fascinating. Can you tell us like a little bit of what really drew you into respirology? Because I know you're very passionate about the lungs.
I do love the lungs. I think what I really like about respirology is that you sort of cover all age groups. So even when we think about really premature infants who have specific respiratory pathology related to being born prematurely, all the way through early adulthood. But we also have that same kind of breadth of practice in terms of levels of acuity. So there are some children who maybe snore when they sleep or have a bit of asthma who function really well and don't have a lot of what we would say is pathology, and you can really do a lot to improve their quality of life, all the way to supporting children who are having the most invasive kinds of cardiovascular respiratory support in an ICU. So really, in terms of practice, there's so much to challenge you because each patient has such unique needs.
Sounds a lot like palliative care. It's also pretty
Like
challenging. And what about the world of dyspnea? This is a big challenge, and palliative care obviously overlaps a lot with the lungs. What's happening out there in the dyspnea world? How can we best manage this?
Yeah, I think the answer to that question is probably not enough. We know that dyspnea is a really distressing symptom. I think it's really distressing to experience, and it's really distressing to watch someone experience breathlessness. And the way dyspnea is managed right now from a pharmacologic perspective is essentially identical to the way it's been managed for the last 50 years. I actually gave a talk to a group of respirologists, one of whom has sort of been a bit of a mentor to me, who trained in the late 70s, who said, okay, but this is what we've been doing since the late 70s, so what's new? So my hope is actually getting different multidisciplinary teams to actually use the tools we have to manage dyspnea. So palliative care physicians are really great at starting low dose opioids, but I think a lot of other teams are reluctant to do that. If we think about, for example, children with cystic fibrosis who have a lot of dyspnea when they go through pulmonary exacerbations, I've used opioids in that population working as a palliative care doctor, and it works in that population. I think a lot of respirologists are reluctant to because they're worried about constipation, which is a feature of cystic fibrosis, but certainly encouraging them, showing them how to use those opioids appropriately, because there is a period of time during a pulmonary exacerbation of cystic fibrosis where you're waiting for antibiotics to take effect, where children and adults are quite dyspneic, and certainly that management is appropriate. I've also known children with cystic fibrosis who sit with a fan attached to their bed. They'll bring in a fan from home, and to really make sure that you communicate to other teams that may not have knowledge of dyspnea that that's something that can be effective where your institution permits the use of fans.
Yeah, and that's so interesting. Do these kids figure out that a fan helps them?
Yeah, they kind of intuitively figure out, like, oh, it's kind of nice to have a fan, and I just like being cold. What about if I move your fan in this direction? No, it doesn't work the same way, right? You like that feeling of the air over your face, and then that can be an important part of a care plan for a child who might have frequent hospitalizations, and even a part of care at home.
Definitely. And you kind of mentioned the fact that, other than palliative care physicians, people sometimes feel pretty hesitant to use morphine and opioids for dyspnea. But what do we know about the use of opioids, low dose opioids for dyspnea? Is this something that's safe?
Yeah, incredibly safe and very effective. It really is kind of the mainstay of our management of dyspnea. We can use low doses, even 25%, 25 to 50% is kind of what I use of your starting dose for pain management. It's really effective in managing dyspnea. A lot of these patients are going to be opioid naive, so these small doses are going to be quite effective. Really, I think very appropriate, and I've seen it have excellent effect in populations where it hasn't been used traditionally.
And it's safe for those patients because, we always hear about, respiratory depression or, decreased saturations from opioids, but what's your experience with that?
So my experience is it hasn't been an issue. Again, these are small doses of opioids, very safe starting doses. And I think in particular, if you're able to keep an eye on your patients, can be used very effectively. So I feel very confident in recommending the use.
That's great. And it sounds like you're spreading that message beyond sort of the traditional borders of palliative care. Although, cystic fibrosis, perhaps not always in North America needing palliative care in a big way, but, our global audience will know that, many, many patients that they see with cystic fibrosis do require a lot of palliative care support in other places.
And I think we do still see some pediatric mortality in cystic fibrosis. And I think very, very fortunately, not to the same extent that we saw 30, 40 years ago. And a lot of really fancy therapeutics are being used in North America for cystic fibrosis, but they're exceptionally costly. And certainly all patients who have chronic diseases associated with symptoms like dyspnea and pain should be getting managed, not by their primary teams, but by symptom management teams.
So they can benefit from palliative care, even if they're going to live for a very long time.
I think so. Yeah. I think I know in my respiratory training, I didn't ask my patients with chronic disease about pain necessarily. And it sort of became part of my practice as I did more palliative care. And there is research to support that. I think there's a lot of unacknowledged pain in adolescents with chronic disease.
That sounds like an area where definitely we need more research in all fields, not just respirology, I bet.
Yeah.
And so just to wrap up, what would be some of your, you've got the perspective of being a respirologist and being a palliative medicine specialist now. What would be some of your advice for us in the field of palliative care? This is a podcast that's really focused on our palliative care global audience. Are there some key pieces of advice you can bring from respirology that you want to share with all of us?
Yeah, I think when we think about respiratory pathology, we look at objective measures. We look at things like oxygenation and ventilation. So looking at how much do our patients have the right amount of oxygen? Do they have the right amount of CO2? And to also look at our patients and how therapeutics are affecting them, because certainly respiratory technology is not without consequence and patients tolerate it to varying degrees. So really to be very patient-centered in our application of respiratory management. But the other thing I would encourage palliative care clinicians to do is to engage with different multidisciplinary teams and to engage with different subspecialties where they're available, because I think we have a lot to learn from each other.
Thank you so much for joining us today, and we hope to have you back in the future to tell us more about what's happening in the world of respirology.